Dr. You will allow me to share my screen. So I don't know whether you are able to see my screen. Kindly confirm.
Yes, we're able to see your screen.
So thank you very much, everyone, for joining this webinar today, and Happy New Year to everyone. And you will allow me to talk about the overview of the cervical cancer. And I will now focus on the screen and treat program. So as earlier alluded by Dr. Afrin, cervical cancer is now the second in terms of mortality, and this is something which is preventable. And I think this should now sink into our minds as we tackle this topic of cervical cancer. So it is a cancer that arises from the cervix, and we know anatomically this may not be visible for our women, and with that it becomes difficult even to know it early. So a lot of diagnosis happens at late stage, and that's why screening and early screening and following of the calendar as per the schedule is very important for us to advocate to our population. So as we know, this is a cancer which is 99% associated with infection from human papillomavirus, which is majorly sexually transmitted. So if we talk of HPV, it may also be associated with other cancers, but for today, we just look specifically for the cervical cancer. So for this type of virus, we know it is divided into two. We have those we call the oncogenic one, or what other people call the high-risk ones, and majorly that is type 16 and 18, which is associated with the cervical cancer. Then we have a group of HPV, which is classified as non-oncogenic, or what people call the low-risk one, and majorly type 6 and type 11, mostly associated with the warts or the genital warts. So the lifetime of acquiring this HPV in women is around 86% by the age of 50, those who are sexually active. And the problem with HPV is not automatic that if you acquire HPV today, then automatically you're going to have cervical cancer. The problem comes with the persistence in infection. So the word persistent is very key in terms of HPV infection and the risk of developing cancer in future. So it normally takes more than 10 years and goes up to 15 years for women with this lesion, which is as a result of HPV infection, developing cancer disease. So I think this is a lot of time for us to act as healthcare workers and advocate more on screening for our women. So we get that almost 9.1 or so of the general population of women will harbor the type 16 and type 18, the high risk one. So what do we do when we have these clients being harboring this type of high risk HPV? As our healthcare providers, what is our role in terms of following up this population? So the peak age for vulnerability is at 35 to 49 years of age. And we see that HIV makes these women 6 times more risk of getting invasive cancer disease once they have been attacked by the HPV virus. But this may be attributed to reduced immunology. And as a result of this, I think it is for us to have a lot of a lot of concern about this population so that we follow them early, frequently, as opposed to the immunocompetent group. So we are also attesting that cervical cancer, once diagnosed as a disease, actually causes emotional trauma. There is a part of financial burden, not only to the family, but also to the to the government, and there is also part of social impact. So the beautiful word here in red, that is cervical cancer, is preventable, though we still say it is the #1 killer cancer in our country, Kenya. So what do we do? If it is preventable as healthcare workers, what is our role in terms of making this word stand the way it is? Cervical cancer is preventable. So just look at the burden. I know in terms of incidence, cervical cancer becomes #2 after the breast. But if you look at the deaths, now cervical cancer becomes #1. So why this? Is it that we diagnose late the cervical cancer disease to an extent that the prognosis now becomes poor? So it is something we need to think about as a team in the healthcare sector. So if you look at incidence again, globally, look at the sub-Saharan region, the dark blue where Kenya is part of, also now feels the scourge in terms of incidence. That also follows the mortality rate, high incidence, high mortality rate, again, sub-Saharan Africa, where Kenya is. So we need to do something in terms of prevention. Then I was bringing this slide for the global HIV burden, that is as per the 2020. We see the high numbers in terms of infection, and specifically now looking at the burden in Kenya. On the far left, I'm looking at the HIV prevalence, mostly among the women. So this is a group of people who are going to be followed closely, and they're going to add in the numbers that will need close monitoring and even close time or close schedule in terms of screening. So the higher the number, we have a lot of people who will now need to be screened. Basically, that is annually, as opposed to the immunocompetent group. So this is a group which, if we take time in terms of screening, they will be appearing in our clinic at late stage when the disease has advanced, even presenting themselves with the fistulas. So it is a group we need to focus on in terms of screening, early screening, detecting the lesions, and making sure we take care of these lesions before they convert into the cancer disease. So in terms of attribution fraction, Kenya, we have the light pink color. I think we need to do more so that we don't now go to the dark pink color. So our aim is to have the white color. So as health provider, again, let's just evaluate and see what are we doing as a team. So allow me to talk about the strategy for the WHO. And for this, we want to look at the call to action, and we want to remind ourselves as a country that we want to go as per the global strategy, and that is 90-70-90. And in terms of the first 90, we want to advocate that we fully vaccinate the age of the young girls up to the age of 15. Vaccination, I know, works well before the infection. And as a healthcare providers, we need to advocate by sensitizing the community on the importance of doing vaccination, using simple language which they understand, with well-planned entry strategy to the community. So I know As a country, we are targeting almost 3.1 million young girls. And currently, I know for the first dose as a country, we are doing about 61.7%. And second dose, I know is also about 50%, which is great. So we want to gap the remaining around 30% so that we cover the entire young population, as some also graduate to get into the age bracket. So it is for us also to work hard and see how the young girls gets vaccinated. For the second component, that is 70% of women who need to be screened with high performance test by the age of 35. I know currently as a country, we are doing slightly below 50%, that is 48.1%. So we want to gap the 22% more or more so that we just do it better. So some counties within the country are doing very great, almost over 90%. So other counties which are not doing well, we need to pull up our socks just to make sure we gap the 22% and even more, so that all our men are screened early enough so that we have better results in terms of managing this precancerous lesion. Then the third component of 90% of women identified with cervical disease need to receive treatment. And I know we normally have a problem in terms of navigating these clients who need care. So a client diagnosed with precancerous lesion, if you are in a facility, and I want to thank the NCCP and other partners for partnering and availing the treatment gadgets even to the lower facilities. So if we are able to treat these women with precancerous lesion as early as possible, it will be of great help, because referring a client with a disease which has not shown signs and symptoms may make them to take time at home and delay, don't need to appear to the facility when the disease has advanced. So let's navigate, let's do what we can do in the low-level facilities. And once we navigate these clients to the higher facilities for care, it is prudent also to follow up and make sure there is complete follow-up of these patients so that the curve is complete. So that will be very key. So remember about 90, 70, 90, and remember about what you want to do for this to happen as a healthcare provider. So that's a summary of that. Remember, 90% vaccination, 90% of our women of reproductive age or the screenable population are screened, and 90% are navigated and get care out of the screening numbers. So that will be very key for us. Then we have very good policy framework for us to go through as healthcare providers, just for us to remind ourselves. And we also have the National Cancer Screening Guidelines for us to screen more. And now that it is a month for cervical cancer, this is the time we should screen more and even gap the 22%, which we need to do so that we have the 70% screening. So those are available on the NCSP website. Then the guidelines recommendation, we are looking at the eligibility of women who have ever had sexual intercourse, and we target a population above 25 years of age. And for HPV, we target a population of above 30%, just to avoid the overscreening of the below 30 who tend to show that they have the HPV, but with persistent, we now just want to look at above 30 years of age. So screening interval, this will depend on which type of screening method you have used, and we are going to see this on the algorithm. So we have number one here, we have the HPV testing algorithm. And for this, the calendar says that after every 5 years, we should screen for HPV just to know whether we have the virus or not. So the difference here is the HPV positivity among the HIV and among the immunocompetent. So for the HIV positive ones, we want to do it after every 2 years. And for immunocompetent, we should do this after every 5 years. So this calendar is very important for us. We should advocate for this. Then we also want to thank the program for availing the colposcopy machines, the handheld ones at the facilities. So once we have done the HPV and we have gotten that the result is positive, then it is prudent for us to make sure we do the colposcopy just to make sure the cervical physics is okay. So when we perform colposcopy and it is negative, even though a client is having an HPV, then we should rescreen after every 3 years. Then annually, for those who are HIV negative colposcopy, but having HPV virus. Then for the positive of colposcopy, there is need for us to take a biopsy. And if we take a biopsy and we have CIN1, we have CIN2, we have CIN3, then we should also appropriately manage the patient. For CIN1, we just rescreen again after 3 years. For those who are CIN2, CIN3, it is good to just do a lip. And if you do a lip, kindly don't throw away the tissue, subject this tissue for histological analysis, and make sure the margins are negative before we leave this client and say it's now okay. So it is good to do histology on the tissue that we take for the lip. Then if the margins are still positive, some may prefer to do another lip for the second time. And some may just go direct and do the cone biopsies, which gives a very good results. So for the VIA, when the colposcopy is available, it is also good to, if it is not available, it is also good to do VIA just to see whether we have any lesion which can be picked, even though there is also the HPV virus itself. So if the VIA is negative, we don't have a colposcopy, kindly repeat after 1 year. Then remember to refer appropriately when we are not able to do a treatment on a lesion, maybe because it is going endocervically, or it is larger than 75%. So it is also good to master this HPV algorithm. Then for cytology, we just want to rule out the possibility of having the greater atypical squamous cell of undetermined significance. So if you do cytology, kindly repeat after within 3 to 5 years. And if we have a colposcopy again, if it is abnormal, then we need to perform colposcopy and follow the colposcopical finding monitoring which may be required. So if it is positive colposcopy and we need to do a biopsy, let's do a biopsy. If it is negative, let's rescreen within the 3 years. And if it is suspicious and you are in a facility where you can take biopsy, kindly take biopsy and navigate a client where they can get the histological services. Then for VIA, again, I know we have the 3 results or the 3 outcomes for VIA, that is negative, positive, and suspicious. I know we have had instances where we get the Nabothian cyst and still somebody will write suspicious. It's okay to write suspicious just for the second eye to confirm. And if you're referring for the second eye to confirm, kindly follow up and see whether that was done. So for V again, for immunocompetent, 5 years. For the HIV population, we do it after every year. Then allow me to bring this picture, that is the anatomy of the cervix, very key in terms of doing the screening. I know some cervixes present with type 1 cervix, type 2, and type 3. So for type 1, you'll be able to see the columnar and the squamous region. For type 2, partially see the squamocolumnar junction. And for type 3, you will not be able to see the squamocolumnar junction at all. So majority of type 3 patients may lose out to be screened properly, maybe because of poor specular technique, or we have preparation of the patient is not done well. Remember, we need to empty the bladder, we need to empty the rectum, or we have poorly positioned the gland. So with that, we are not going to see the full anatomy of the cervix. And during mentorship, you'll say you'll see the colleagues say this is clean. We don't need even to apply the acetic acid. And actually, we cannot see the entire cervix. So it is very important to classify the type of cervix you are dealing with, so that in terms of screening, you see which method is good for which type of cervix. So for type 3 cervix presentation, it may not be easy to use the VIA and say this is VIA negative or positive. Remember, we must see the entire squamocolumnar junction to say at least if we apply the acetic acid, we can pick changes. So for those with type 3, VIA may not work well. So it is important to have a proper view or a complete view of the cervix so that we can perform better VIAs to our clients. Then the reports, the outcome that is negative, it can be a set or white positive, and it can be suspicious. I know some of the referrals you'll see a bit suspicious as a result, but it's still okay, that we need to review and get the proper presentation. Then acetowhite, it is very good also to describe the acetowhite lesion in terms of extension, in terms of color, the borders, and also the size and location, because this is also going to determine what type of treatment we are going to provide to a patient. So any lesion more than 75% may not be good for procedures like cryotherapy, or the lesions that extend endocervically may not be good for cryotherapy as a method of treatment. So we need also to do that. So I know because of time, I will just now go just to show these pictures, just to help us identify the acetowhite lesion. Remember to look at the color, the borders, the location, and even the thickness. Then I'll go through just some of the treatment very fast, and I'll start with the cryotherapy. I know we have done this, but what I want to talk about in cryotherapy, kindly, if you're doing cryotherapy, make sure the cryoball forms. Some of the cryotherapy from the mentorship may find we have done cryotherapy, but no cryoball formed at all, or because the patient was not prepared well. And when doing cryotherapy, avoid just attaching the cryoprobe on the speculum, especially the metallic one. It will make our mothers have some discomfort, and the procedure may not be that successful. So a method of treatment, but also let's see how to prepare our clients well. Then we have the thermocoagulation. We can use the TC or the Liga equipment just to do thermocoagulation, which is going to ablate or destroy the transformation zone at high temperatures. And this only takes 30 seconds to do. So very important equipment for us to work on the precancerous lesion at our lower level facilities. So for those who have not seen TC, this is the TC, and we have another one called the LIGA. So this will be the presentation after treatment with the thermoablation. It will grow back to normal, and we just need to assure the mothers. But once we do the thermocoagulation, please tell the mother when to return to the hospital and the danger signs which may be encountered. Post-treatment instructions still applies to all in terms of when should we resume the sexual activity, when should we come back for screening, and when should we come back when we see other abnormality post-treatment. So for the inputs, we need to escalate more training both on high and lower levels just to close the gap, then advocate for guide development, and that will include the community component, then see on how to put more effort to get more devices for treatment, and also develop structures like the hub and spoke so that we can have proper referral system within our counties. Then documentation, very important, and the key performance indicators which we need to track as a country that are shown. We need to document, and this will also inform us where we are, the next step, and the planning on our side. So what we need to carry home, I'll read the one in red, that is cervical cancer is 100% preventable, and we must now internalize the WHO strategy to control the cervical cancer, that is 90-70-90. We are somewhere, we need to work hard to reach this. Remember, we only have 6 years. It is 2024. By 2030, we should achieve this. So thank you very much, unless there is a question.
Thank you, Kennedy, and for that wonderful presentation. I think we'll keep the questions for the end. So kindly type all your questions in the chat box. So let's listen to our second presenter. Our next presenter is Dr. Anisa Mburu. She's a gynecologist at the Aga Khan Hospital in Mombasa. She's a clinical researcher with a special interest in HPV-associated cancers, particularly cervical cancer, pediatric cancers, and palliative care, with numerous publications and ongoing research. She's an early career faculty member of the International Gynecological Cancer Society, as well as a mentor for the International Cancer Institute. Dr. Anisa is an IGCS certified program trainer of trainers for the pre-invasive disease program and co-chair of the palliative care workshop for the IGCS. Currently, she serves as an expert advisor for the WHO subcommittee on the cervical cancer elimination strategy through surgical capacity building. Dr. Anisa has participated in the curriculum development and colposcopy training of primary healthcare workers for the joint effort between the National Cancer Control Program and the Clinton Health Access Initiative. So let's welcome Dr. Anisa. Dr. Anisa, karibu.
Friends, for the warm welcome, and thank you to Kennedy and NCCP for inviting me to share a bit of knowledge about cervical cancer, one of my favorite topics to talk about, and hopefully soon we'll never have to talk about it. So my task is a bit easy. Just going to talk about a few cases that we've seen of cervical cancer and essentially give you a few tools that you can actually use to move forward whenever you have a patient in front of you. So we're looking at breaking the silence on cervical cancer solutions in screening and early referrals. While our main topic today is on screening, first of all, I do have no financial disclosures I have to mention. And one thing I will say is the fact that this being January, which is Cervical Cancer Awareness Month, it literally sets the stage for us for the entire year, where we can start with a purpose, start with a resolution that we are going to join the fight in the elimination of cervical cancer. One woman screened is one death averted. And if we take this throughout the entire year, There's several opportunities that knock on our doors, willingness to be able to save women in our practices, in our lifestyle, whenever we're walking around streets and whatnot. There's so many women we meet, and it doesn't take much to just include, mention to a woman, have you been screened? Tell them a little about it. You lose nothing, absolutely nothing. And while our topic today is mostly on the screening, I will touch very briefly on primary prevention, where we're talking about the vaccine. And then, of course, a bulk of the presentation today will be about secondary prevention, which is about the screening to identify these diseases at the earliest stages, and a little bit about the tertiary aspect of cervical cancer. So bear with me for the next maybe 25 to 30 minutes. So I do not want to belabor this point, but one thing clear is that we have those two groups of HPV, the high-risk types and the low-risk types. Low-risk cause genital warts, benign lesion, respiratory papillomatosis, not necessarily cancerous. Very ugly, very scary to look at, but not cancerous. The one we're really worried about are the high-risk types. 16 and 18 in Kenya have been shown to constitute about 96% of all cervical cancer cases. And we are still having a lot of patients positive for 31, 33, the other type Bs, they're so-called. And that means these women still need to have additional testing. We know that HPV virus is the commonest sexually transmitted virus amongst both men and women. And studies have shown that for every woman in her lifetime, she's at risk of getting HPV infection by about 85%. For the men, it's on the higher side at 91%. Then we have this subgroup of sexually active adolescents, where the prevalence is very high within the first year within initiation of sexual debut, with a high of 50 to 80%. And that's why we really focus on this age group and ask them to delay sexual debut as much as possible, because we know they're not immunologically nor anatomically capable of fighting this infection, as well as those who are 24 years and above. And so I will start with the very first case. And unfortunately, I don't see anyone I can point out to, so we're not going to do a Q&A. But the cases I share, I want you to think as we go through them, think through the answers, think what you would do, so that when you're faced with this real life cases, all of them are cases that I have dealt with or my colleagues have dealt with, both nationally and internationally. So the first case we're going to talk about, this one, I think I shared in a presentation some time back, but it's a patient I saw last year, 15-year-old, Nalipara, she'd never been pregnant, and came with a history of abnormal vaginal discharge, causing a burning sensation after intercourse and a lot of uncomfortable vulval pruritus. The discharge, she described it as creamish, curd-like, and pungent in smell. She's 15, but she has had 2 sexual partners in the last year, and her age of sexual debut was 14 years. And so apart from wanting to be treated for the discharge, she asked, can I give the HPV vaccine? Now to the audience, I ask you, would you give her the vaccine? What do you know about the vaccine? And so we'll talk about that a little bit. So according to the Kenya national guidelines, the primary target group for the HPV vaccine reception is adolescent girls aged 9 to 14. Across the world, this figure changes to 9 to 15, 9 to 16, it varies. And again, these are the Kenya national guidelines. I specifically put a picture of a boy to the right so that I can tell you that boys should also be vaccinated. The reason to vaccinate girls, as we all know, was due to some reasons, not scientific or based on medicine, but more of availability. And that's why girls were specifically chosen for the vaccination initiative. But boys should also be vaccinated within the same age group, hopefully before the first sexual encounter. And the reason for this is that studies have confirmed that sexual naivety, when someone has not been exposed to the HPV virus, they get the vaccine, the kind of immune response that the body launches tends to be stronger and longer lasting compared to a natural infection. And this was a study done also over a 25-year period from, I think, 1995, where they followed up the immune status of about 3,000 women, and the amount of antibodies that these patients had over a 20-year period was essentially high and maintained high. And that is why we try to advise the ones, our young girls, young boys, 9 to 14, before sexual debut, to get the vaccine. It works best that way. Now, when it comes to just the vaccination and to see how it helps preventing in the risk of invasive cervical cancer, I'd want to share a study that was done in Sweden that looked at a population of almost 2 million women who are aged between 10 and 30 years of age. About 530,000 of them had received at least one dose of the quadrivalent HPV vaccine. Excuse me, that was being studied at the time. And these women were followed up until they reached the age of 31. Out of this cohort, cervical cancer was diagnosed in 19 women who had received the HPV vaccine, right? But in those who had not received, 538 women got cervical cancer. And this is invasive cervical cancer. So you can see in terms of prevention, those who do not get the vaccine have a higher risk of developing cervical cancer. But for those who are visual oriented like myself, I shared this chart, the bottom right, and work with me. On the x-axis, we have the cumulative incidence of cervical cancer, and on the x-axis, we have the age of follow-up. Remember, the study was going up to when the patient gets to 31 years. And as you can see, for those who in orange, they were unvaccinated. And so after the period of about 23 years, they had a steady increase. I hope you can see my cursor. They have a steady increase of cervical cancer incidence. For the women who are 17 to 30 years of age, yes, they did exhibit a form of reduced incidence, meaning they had some form of protection, but it's not as good as those in green who are less than 17 years of age and who had a continued and sustained low incidence of cervical cancer. This is a paper that's available online and it's free of charge. So I would really recommend that as many as can to have a read and see how it goes. Now, as much as we talk about the vaccine quite a lot, there are other primary prevention strategies that we use. And one of them is education. We need to talk to these young people, tell them about safe sex, urge them to abstain as long as they possibly can, use condoms, and of course, limit the number of sexual partners. We need to explain to them how their body works. People tend to shy away a lot from talking about the anatomy, talking about the conversation that I say in quote, the birds and the bees. But it's really important to explain to our young girls or young boys what exactly happens during puberty, what menstrual cycles are. And if we educate these young people to the point that even the boys understand when a girl is on her period, there's no need to make fun of her, it's not an abnormal thing. And for the girls to know that when they have an abnormal discharge, they need to get checked. And all this functioning, it goes a long way in helping these women and young boys to understand how their bodies work. And the point is, or rather the hope is, with this kind of education, it will lead to lifestyle changes where they can avoid smoking and have prevent other risk factors that I'm going to talk about now and keep them safe from developing cervical cancer. I've shared this slide before and I will share it again. It literally just shows us a pathway of the kind of risk factors that are there for cervical cancer. And we've mentioned early age of sexual debut, grand multipolarity, we need to tell them about using family planning. One thing about smoking, which you can see right here, is that even for those who smoked for a while during, say, their young adult life, then they smoked for even up to 10 years, then they stopped. The effect of smoking can still last 20, 30 years down the line. And I'll even let the lung cancer people tell you about this. But it is one of the main problems or risk factors for cervical cancer. We talk about low immunity. Sometimes this is not something we can do much about, especially if someone had a kidney transplant. But things like diabetes is something that we can actually manage by healthy lifestyle. Women who never have screening at all in their lives, then they're at the highest risk of cervical cancer. I do not need to talk about multiple sexual partners. I think this is as clear as the light of day. And this is both for men and women, because the man can bring an infection to the woman and the woman can get it out there wherever she is. And of course, STIs like HIV, chlamydia will always be the ones that lead us into the murky, shark-infested waters that are called cancer. And so when we educate our girls about, and our boys about all these risk factors, then they can take matters into their own hands and be able to stop this kind of disease progression. So I will change gears a little bit and talk about secondary prevention, which we all know is now when we're screening women to identify these diseases in the earliest stages before the onset of any signs and symptoms. As we know, cervical cancer or the precancerous changes do not have any signs and symptoms. So even if someone has a HPV infection, they will not have any normal discharge, any foul smell, any pruritus. They will be asymptomatic, and that is why we are screening them. And this is something that I needed to make clear. I've had people, in fact, just yesterday, I was being asked by some nurses that they'd heard that people are getting benzopenicillin for HPV infection. And it blew my mind that it could go so wrong in this day and age, that we're giving an antibiotic for a viral infection. Please, let's not mislead people. Let us not mislead ourselves, and let's get our facts right. So I'll start us off with a case. This is a patient I actually saw just a week ago. 28-year-old, had had 2 vaginal deliveries, the last one being 3 years ago. She walked into my clinic just for removal of implant because she wants to get baby number 3. She had done a pap smear. She'd been very religious in doing her pap smears over the last, say, 5 years. And she had had a negative test, which was good for her. So, of course, I talked to her about cervical cancer screening using a high performance test, which is HPV. And I'm lucky in my setup that we do have it available. And she did turn positive for high risk type 18. As we know, type 16 and 18 are one of the very other type A's that are associated with a lot of cervical cancer. So, of course, we put her through a diagnostic test, which is the colposcopy and biopsy. This is her cervix. And I know my colleague talked about some of the changes that we look at during colposcopy. And as you can see, she had a relatively good looking cervix with some squamous metaplasia, which was not a problem. But if you look towards the right side, I hope it's right for you as well, but the right side of the screen, there was some acetyl whitening. And we couldn't quite see what was going on. So I also took an endocervical curettage. And the biopsy came back as a high-grade squamous intraepithelial lesion, or CIN3. So we did a lip, and it confirmed the same diagnosis. Okay, I'll go to case number 2 before I discuss anything else. Now, this one is a 33-year-old. She had had 6 vaginal deliveries. She had a complaint of recurrent vaginitis. This presented with a lot of foul-smelling discharge, a lot of uncomfortable vulval pruritus, a burning sensation on coital activity, and she had a history of traditional therapeutic burning of the cervix and vagina. In Kenya, or at least for those of us here, you understand there's a community that has, they use a hot metal rod to burn the cervix and the vagina whenever they're treating things like recurrent vaginitis, infertility, and heavy menstrual bleeding, and so on and so forth, which I do not recommend. So please get me clearly. So from her original gynecologist, he had done several high vaginal swabs, but there was no growth of any organisms. So he had screened her for cervical cancer and used a high performance test, which is HPV, and it was negative. So, but because of that history of burning, this history of recurrent vaginitis, we still did a colposcopy. As you know, a colposcopy is a diagnostic test. But then maybe let me stress this here. We screen with HPV testing or pap smears, but colposcopy is for diagnosis. So when we did a colposcopy for this young woman. This was her cervix. As you can see, it's looking very red and angry. And even if after application of acetic acid, she had some aceto-white areas, but they were not quite well defined. And so we didn't really know what was going on. So of course, we took biopsies. And the biopsy came back as chronic cervicitis. I did biopsy in several areas, and all of them confirmed chronic cervicitis. And luckily for her, she did not have a precancerous lesion. Okay, so sometimes you can have a red and angry cervix, but it's just cervicitis and nothing more. So the third case, this one, she had 2 vaginal deliveries and 3 miscarriages. And in her last delivery at about 8 months ago, she had a cervical tear. And she had a history of heavy menstrual flow. And so the reason she came to see me was that she wanted a hormonal IUD, mostly to control her flow, because she'd even gotten slightly anemic. So of course, talked to her about cervical cancer screening, and she turned positive for type 18. We did colposcopy and biopsy, and this was her cervix on colposcopy. This is an image even before application of acetic acid. You can already see that she's easily bleeding to touch. She has some areas of abnormal blood vessels, and the biopsy came back as a high-grade squamous epithelial lesion, saying 3. And so we did a lip, which confirmed the diagnosis, and the margins were good. So the last case I'm going to discuss, this one was as recent as last Friday. A 26-year-old, para 1, her last delivery was 1 year and 6 months ago, had a vaginal delivery. Swelling, she had a swelling in the perineum for about 2 years that had even predated her pregnancy. It was painless, so she didn't worry about it. She had no problems engaging in coital activity. It was not discharging, it wasn't increasing in size, it was just stable, just there. And so she had gone to a local pharmacy where she'd been given some pessaries, and she'd even been told to do some sit baths, but of course it never improved. So because she had some free time over this last holiday season, basically, she decided to just come get it checked, make sure there's nothing happening. And because January being Cervical Cancer Month, I think she had a lot of hullabaloo in the media, and so she decided to come get checked. She had done a pap smear a year ago, and it was normal, negative for any intraepithelial lesion or malignancy. And this was the lesion on her vulva. As you can see, it's quite swollen. In a different forum, I would have asked you what you think, but it is Bartholin cyst. And so, of course, we educated her about cervical cancer screening, we did HPV, and she turned positive for the high-risk type non-1618, meaning one of the other type Bs, 31, 33, 52, 58 BTC. So we prepped her for marsupialization and colposcopy. When we were doing colposcopy, that was her cervix. And remember, she's 26 years old. She had had a negative pap smear. That's her cervix. So it was bleeding quite easily. She had some aceto-white lesions. She couldn't even go through into the cervical canal. So of course I took a biopsy, and unfortunately it has come back showing microinvasive squamous cell carcinoma with lymphovascular space invasion, which we'll talk about in a bit. And so we've sent her for metastatic workup, but she has only 1 child. So she still wants more babies with that cervix. So again, we'll talk about this in a bit. So when you look at this, 4 cases that I've shared, if there's one thing that would stick out, or that a point that I wanted to make out, is the fact that all these patients came to hospital for a totally different reason, and I was just doing opportunistic screening. It's not a screening that is recommended or scheduled, regular screening, but just walking in for a problem A and you end up finding problem B. And this is one of the reasons that Kenya is really lagging behind the WHO 2030 goals in elimination of cervical cancer, because we haven't yet set up a system that allows patients to be screened, to walk in and get screened as often as possible. I was impressed by one of the countries, South Korea. for every woman who was born on an even numbered year, like 2022, they make sure that every even year she's screened. For those who are born in an odd year, they screen her every odd year. And that has really reduced the amount of cervical cancer patients that they're having in South Korea. And I wonder what is so wrong with Kenya that we cannot reach such goals and be able to screen women, and not just because we have the women who have actually come to hospital, who've come to a hospital that is a healthcare worker who's actually aware about cervical cancer, and that healthcare worker also has tools to do cervical cancer screening. So you see, there's a lot of work that we need to do. And early in this month, as January rolled in, the WHO set out different country profiles about how each country is doing in terms of cervical cancer, in terms of screening, vaccination, and all that. And the figure that they had for Kenya was this, that so far as of 2019, I know it's a few years back, but as of 2019, only 1 in 10 women would have been screened, 10 women, sorry, that have been screened for cervical cancer, and that we are only at 17%. Of course, right now we have only gone to about the 23%, I think, when I last saw it. So, and they're supposed to have reached over 70%. So we are doing very poorly. And this is why we're having this talk, so that we can appeal to as many as have ears, that we need to talk to our women, encourage them at every single opportunity up until we are able to establish regular screening services in each and every hospital, that they have to get screened, they have to come to hospital and be able to make sure that the cervical health is at 100%. Of course, when it comes to cervical cancer screening, there are different guidelines. This one's on the left. I just picked it from ACOG. They go for 21 to 29 years old to get a pap smear, but we know that several other organizations take 21 to 24 or 24 years and below to get a pap smear. Now, guidelines are good. Guidelines give us an idea of what to do. However, your clinical judgment is very important. For example, the two cases that I shared, one was 26, one was 28, and they already had a pre-invasive cervical cancer lesion. So, and one of them, her first intercourse was at 16 years. So there's that mentality that, yes, women in the early 20s, they're very sexually active, and yes, they'll almost always be positive for HPV, but they will clear it, and that's great. But there's some women when you talk to them, follow them through, get their sexual history right, you will see that this one naturally needs a HPV DNA. So I know for most of us, we put a cap at 25, and anyone 25 and above, we do screen them with HPV as long as it's available. Those who are 30 to 65, again, please do HPV testing on them. You can co-test with a pap smear, but already our patients don't even have the finances to do HPV. So you want to insist, oh no, you need to do HPV and pap smear. It doesn't make any financial sense. And you're using 2 screening tests for a patient. Again, it's not really necessary. Just one high performance test, which is the HPV DNA, which is quite efficient. And studies have confirmed it, because when you look at the sensitivity of HPV DNA testing, we have mean of 92% versus 40% for the pap smear. So really, if you're going to choose something that is a high performing test, essentially, of course, you go for the HPV. Of course, I know there's a lot of financial issues with access and everything, but that is why as healthcare providers, we need to put our foot down, and our collective foot down, and insist for hospital management that we care about the health of our women, and we need to have HPV testing, because the more we increase the demand, the more the supply will be made more available, and the cost can come down. And we find the diagnostic accuracy of pap smear has been mooted by several factors, inter and intra-observer variations, the stealing collection, steep lesions, so many other problems, and just so if you want something that is completely objective, the HPV is superior in terms of everything. But if you have absolutely nothing, please don't let that woman go away. You can still do a visual inspection with acetic acid. As long as it's in good hands, you follow the read score that Kennedy showed, the table of what you're looking at, the margins, the acetal whiteness and things like that. Score the patient. Always, when you're doing a VIA, I just see people doing it on their own and then they decide what they're writing. Make it objective. Have the chart, the read score or the sweet score, whichever you choose to use. Have it there. Mark every factor, score the patient, add the scores, and you have an objective screening for that woman so that it's not just by gut feeling, oh, I see something suspicious, or no, it has to be based on science. We are scientists. We went to school for a reason. Let's make use of that, the knowledge that we've gained. And of course, as we get more into HPV testing, we are seeing a lot of HPV positives. And so the future directions are that we want to specifically diagnose or put women who are HPV positive through diagnostic tests who actually are at high risk of developing cervical cancer. And so HPV mRNA testing is one of the things that has been proposed as it demonstrates similar efficacy, while quantitative methylation specific PCR DNA tests have been shown that it can actually identify or has a high sensitivity specificity for detecting any CIN2+ or even cervical cancer. So these are tests that are coming up. There's a lot of studies ongoing. And so I'm hoping that Kenya, we can also catch up. The ASCCP has set up an algorithm for risk estimates in terms of what do you do when you have a particular lesion, a particular screening test that has turned positive or negative. And it's quite good. However, I find a lot of trouble actually, because there's some elements that are okay in a high-income country, but for us in a lower middle-income country, we are not able to do like regular pap smears and HPV test. Our loss to follow-up is super high, and so sometimes for this risk estimates by ASCCP might not quite apply in our situation, but the goal is that we will be able to reach international standards. We're talking about women, but there's things that men should know. And I hope everyone, the men in here who have been falling asleep, please wake up and listen. This is for you. HPV will affect the men as much as it will affect the women. You are not exempt. And for the males, as you saw, your lifetime risk of getting HPV is up to 91%. So you do not go scot-free. And it can cause cancers in the men as well as the women. And we're talking, and not just for women, yes, they get a cervical cancer, but for the men, they get anal, apologize, they get anal cancers, penile cancers, and of course, nasopharyngeal cancers, because of the kind of sexual practices that we're engaging in these days, from oral sex to anal sex, and even anal sex, not just between men and men, but even men and women. So this increases risk of anogenital cancers as well as nasopharyngeal carcinomas. However, for men, you're a bit, can I say unfortunate, because there's no yet approved screening test for HPV cancers for you. We literally have to wait for symptoms and signs. That's when we diagnose you, so we can screen you. So, poorly, but hopefully we'll get there. Now, the one key thing, the point number 4, is that for women, when it comes to the lifetime risk of HPV infection, yes, it's high, but once you get to about 65, 70, the lifetime risk goes down because this is menopause, a lot of things are happening. So risk for women kind of goes down over time. But for the men, it remains high throughout their lives. So it's not that, oh, when I'm 70, I'll never get penile cancer, or that I'm 70, I'm not going to get anal cancer. Please, for the men, if you have patients who are male, for the men even listening, if you have a lesion on your penis, you have a lesion around your genital regions, please get it checked. Even if you're 70 or 80, you have to get checked. This one, I cannot stress it enough. Point number 5. Boys to get vaccinated against HPV, and I really hope that the national cancer, I forget who, the people in charge of vaccination, they can actually change those guidelines that the vaccine can be free for both boys and girls. We are not in a state where we are having so much herd immunity because all the girls have been vaccinated. We're having vaccines that are expiring in fridges. So please, let's use them before they expire. Let's not turn away boys. Please, let's get them vaccinated as well. And remember, it works best if it's given before sexual intercourse. You can't give it after someone has been exposed, but the efficacy, if you remember the graph that I showed, I think my third or fourth slide, it is not as good, but it's still good enough. So the last point I'm going to talk about is now for those who already have cervical cancer and we now have to treat them. There's a particular group of patients who have cervical cancer that honestly, they terrify me. I'm going to be genuine on this. And these are these patients with this early stage cervical cancer. It is one of those stages that can go either way, badly for both you and the patients. And this is unfortunately one of the stages of cervical cancer where we are having a lot of, can I say, fights or arguments or displeasures between different specialities. Sorry. Now, there's been there are a lot of studies. Excuse me. Sorry, my time is up. That's what my throat is telling me. When it comes to early stage cervical cancer, we're talking about stage 1A1 and 1B2. If you don't know the staging, please go read. It's very, very important for you to understand it. And so they are managed in different ways. And we've had a lot of talk about even minimally invasive surgery, which we do not recommend in this particular group. And now we're talking about whether they should get simple hysterectomy or radical hysterectomy. Lymph nodes have to be removed. But, you know, there's this mentality that, oh, everyone can do a hysterectomy. But let me tell you this. If you do not understand the cancer process, you're going to mess up the patient. And that's why we are seeing a lot of cut-through tumors, meaning a patient was seen by either a medical officer or a general gynecologist. They thought, this is just a simple early stage cancer. They did a simple hysterectomy. Histology comes back and you've cut through tumor. So that patient really goes through a lot of problems because they have to go through bimodal treatment. There are two papers on this particular topic that I would really recommend that you read. The concept trial has been out for the last, I think, 3-4 years. So please, those who interested, and it would be good for you to avail yourself this knowledge. There's a SHAPE trial that is yet to come out, but at least the abstract is out. Also talking about these early stage cancers. Please, let these women be treated by the right people at the right time. It is one of those stages that you have to really be meticulous and select your patient in a targeted fashion. Not all patients are for a simple hysterectomy, and not all doctors are for doing radical hysterectomy. And I will talk about this case. We actually discussed this yesterday in a tumor board from Zambia. A patient who 65-year-old was menopausal. She'd had lip done twice because she had a persistent CN3. She went to India because she had the finances to do so for further treatment, and she had a hysterectomy and bilateral salpingo-oophorectomy. The histology came that she already had squamous cell carcinoma of the cervix. She had a depth of invasion of 5 millimeters. They say the paracervical and parametrial margins were free, but again, she had a simple hysterectomy. I do not know how they got this, but the vaginal margins were free and she did not have lymphovascular space invasion. So by staging, she was essentially a stage 1A2, but her nodes had not been removed. For those who understand early stage cervical cancer, we cannot manage a patient without knowing how the pelvic nodes were. So the Zambian team decided to take her for completion surgery to remove the nodes. But of course, any pelvis that has gone through surgery, it's a mess to go in there. She had a lot of adhesions, got a small bowel injury, so they had to abandon this surgery. So I asked you, what was the next step for this patient, to radiate her or to observe? And this is a typical case that we see a lot of from patients who are referred to us and we're left. Do we overshoot or undershoot? We don't really know what to do because they've already been mismanaged or undermanaged. So when we talk about locally advanced cancer, and this is my almost second last slide, we're talking about stage 1B3 to 4A tumors that are beyond surgery. And the reason it's beyond surgery is because of things you hear us talking about, Sedley's criteria, Peters criteria. I will not go into these details. Remember, I mentioned a patient had LVSI at some point. These are the things that we look at. If a patient is sent to me with a histology, I want to know what is the depth of stromal invasion, what is the lymphovascular space in the room. If you do not know these factors, you will not be able to manage this patient appropriately. You will not even know to ask the pathologist to look for these factors. And that's why it's really important to, when you get these patients, refer them appropriately. Right now, the number of GYN oncologists is really increasing. So there's always someone you can ask and consult. So this is the maybe last case. 57-year-old managed in one of the hospitals in Kenya, had postmenopausal bleeding. She had a mass in the cervix that was 5 centimeters. A biopsy was taken. She had an MRI. They did the works, but now the MRI showed that she already had pelvic node involvement. And so the doctor seeing her decided to take her for a radical hysterectomy and pelvic node dissection. The histology came back that she had a huge mass, 6 centimeters already. That's a 1B3. Parametrial involvement, already 2B. Positive vaginal margins, already 3A. Pelvic nodes, positive, already 3C. So are you saying this is a patient who has all the risk factors for very advanced disease? And apart from that, and this is now the point that I'm making, when you see like the nodes, 1 out of 3 submitted, 2 out of 2 nodes submitted. For those who have studied this kind of things, you know that there's about 11 to 16 nodes in the pelvis that need to come out. So if someone submits only 3 nodes, that means they're not competent enough to do a pelvic lymph node dissection. And at this point, when you refer this patient to me, you're stuck. What are you supposed to do? Do you go in to remove the rest of the nodes? You just send her for radiotherapy. You've already sort of messed the patient. Oh, sorry, I forgot there's a third case. And this is the last one, yes. So another case. Dr. Frin, do I have time to just finish this?
Yes, and you said, please finish up, yes.
All right, okay. So this should be it. So 46-year-old came in with a 2-month history and in a different facility again. This one wasn't mine. She had a cervical mass, a biopsy and CT scan was done. And this one, I said, I'm not even going to type it. I will put it here so that you can see it for yourselves. So look at the microscopic description. It says that she has clear cell carcinoma and blah, 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 blah. Now go to the last statement of the microscopic part. And sorry. My mouse is misbehaving. So it's saying no psammoma bodies. All right. So one thing I will tell you, again, as a gynecologist, we are really pushed to understand histology because this is the basis of how we manage the patients. So when I get this kind of a biopsy, clear cell carcinoma is extremely rare in the cervix. It can happen, but it's extremely rare. Then you tell me specifically, put it in bold and even underline it, no psammoma bodies. It makes me wonder the person who's reporting this, whether they actually know what they're talking about. Because psammoma bodies are in ovarian serous carcinomas. So you don't expect, even in a clear cell carcinoma in the cervix, to have psammoma bodies. So if I was not even a gynecologist, oncologist rather, I'd take this biopsy, discuss with someone who understands it better. However, this patient was taken for radical hysterectomy. And again, it came out that 3 out of 6 nodes were positive. So she was already at stage 3C, 2P. So now, when we go through school, we take an oath that we say, do no harm. And if you can see this last couple of patients that I've presented, they all required radiotherapy. Most of you understand this. To go through surgery, there's a lot of side effects that come from surgery. Going through radiotherapy, there are even worse complications. Now, imagine you putting a patient through surgery, then they have to go through radiotherapy. That's painful, and that's hard on the quality of life of these patients. And I beg you, whoever has ears, please listen. These patients, we need to treat them appropriately, refer them appropriately, or if you're not able, call in someone who understands these cases to operate with you, to discuss the cases with you. As GYN oncologists, we have regular tumor boards. It's not that we are stupid, that we always have to talk to each other and find out what is happening. It's because we understand the value of different points of view, and that we can be able to come in a safe space, talk about these things, criticize each other, talk to each other, and be, at the end of it, make a decision for the patient that is for the best of them. Not just the disease, but also their quality of life. And so everyone who knows me knows I'm a great fan of comics. And there's this sentence that comes from Spider-Man that says, with great power comes great responsibility. We have been charged with the power of taking care of patients and their lives, taking care of their health. That's why we went to school for God knows how many years. We studied through nights and days because we wanted to be better, to be able to help people get better. So please, let us understand what we're supposed to do. Know our limits. And again, know our capabilities. It doesn't matter that I've been practicing for the last 30 years. Knowledge keeps changing, knowledge keeps improving. So please don't hesitate. Call someone who's even 20 years your junior, call someone who's 20 years your senior, meet together, talk about it. Let's respect each other in this field, and let's do the right thing for the patients. And so the last slide that I have is just asking you to please refer these patients appropriately. Always call one of us. There's about 20 of us out there, and there's still more in training. We will always be ready to talk to you, help you through, walk you through any steps that you need to, do the appropriate management for the surgery, for the patient. And let's avoid this bimodal treatment. The surgery is then radiotherapy. If you understand the disease process, you would know that this is very difficult to deal with, especially in terms of the patient's quality of life. And I thank you for your attention. I did go over time. It was not my intention, but that's my email. If you have any cases you want to discuss with me or anything, I am open to discussing. Thank you so much. And I apologize for going 12 minutes over, Corinne.
Thank you. Thank you so much, Anissa, for that very enlightening presentation. And I do agree with you, with great power comes great responsibility. So yes, we've learned quite a lot from this presentation. I'm sure we've dispelled some common myths, particularly there's this myth once the transition period from the time a patients acquire the infection to the time patients actually get infection is over a decade. No, that's not the case. We've seen women who are just 2 years have just been sexually active for 2 years, and they're coming with cervical cancer. So kindly, once you have a patient who's sexually active, kindly refer these patients for screening. Screening takes a shorter time, much more cost effective than the actual treatment of cervical cancer. And this is a cancer that is completely preventable. So with that, let me open up the Q&A session. And we can go through some of the questions that people have asked. So just give me a few minutes. So Jane Wanjiru asks, a patient with a history of genital warts that resolved on their own was asking if the risks and is she required to get vaccinated, or can she get vaccinated? Anissa, would you like to take that question?
Thanks, Dr. Akin. You said, lady, I didn't hear the first part, who had what? Genital warts?
Yeah, a patient who had a history of genital warts that resolved on their own. Can she get vaccinated?
Yes, this is like what I said about efficacy of the HPV vaccine. It works best if you've not been exposed to HPV. But for those who have already been exposed to HPV, now in this case, you probably had a type 6 or 11, there's still an element of safety that is that is provided by the vaccine, especially the quadrivalent or the nanovalent vaccine, that will keep her safe from the other types. It will do nothing for the type that she already has, but for the other types, it could give some protection, but it's not as good as if she had gotten it before she was even sexually active.
Okay, thank you, Anissa, for that. The next question is, I think Dr. Anissa answered this question. What's the relationship between cervical cancer and the use of combined contraceptives? However, would you like to answer this? It's a common question we get asked, particularly patients who come for family planning. So Anissa, do you want to take that, or Kennedy, would you like to
Yes.
answer that?
I think, Dr. Nisa, you can take that.
Sure, happy to. So when it comes to contraceptive use, we're talking about continuous use of COCs for 10 years or more. I'm talking every single month you're on the COCs. So this has been shown from studies. It has been postulated that it causes a lot of changes, which we know in how it works to cause the family planning to take place, is that it causes a lot of changes in the cervix, changes in the mucus in the cervix, leaving the patient not appropriately covered by their natural mucus, natural ability to fend off infections. And so this continuous use has been associated with an increased risk of cervical cancer. However, for patients who use it on and off, or they use it for a couple of years at a time, it's still safe. So please do not deny COCs. And of course, COCs have a lot of side effects. So like clots, and suddenly all the other side effects have run away out of my head, but they have a lot of complications or side effects. So we don't recommend use for 10 years at a time. I hope that answers.
Yes, thank you, Anissa,
Yes.
for that.
Yes,
Mr.
Dr.
Kennedy, sorry.
Yeah, just to add
please.
about the use of contraceptive. For those who are screening, I know we may confuse the appearance of the cervix, especially for those who present with ectopy, as suspicious. So if you see the highly reddened area, I think it is also good to have a history or the primary history about the use of contraceptive, just to help you rule out the cause.
Okay, thank you, Kennedy, for that. So patients who are on contraceptives, basically estrogen, you would see that their cervix would have an ectopion. However, I think Kennedy, during his initial slides of the anatomy, he had shared where the squamocolumnar junction is, the old one, the new one, and the transformation zone, and where you would likely find lesions. So it's very important when you're doing examinations to identify the normal anatomy before you look for any abnormalities. So if you don't know what is abnormal, as healthcare workers, it's not really possible for you to know the abnormal. So familiarize yourselves with the normal anatomy. The other question is from an anonymous attendee. What treatment is available for asymptomatic male partners with positive HPV 16 and 18? And can they get vaccinated? Anissa, would you want to answer that?
Yes. So for both men and women who test positive for HPV, there is no treatment. There are no antivirals, there are no creams, nothing that you can give to treat. All right. So, so we just have to monitor in case there are changes that occur, precancerous changes, and then treat if they're there. For the women, you'll do an excisional biopsy or cryotherapy or whatever. For the men now, it has to be an excision. When it comes to the vaccine, then I will refer to the previous comment or the question that I'd answered before. They can't get the vaccine, but efficacy is reduced. But yes, if you can get vaccinated, I'm okay. I mean, even the guidelines say you can get vaccinated up to 45.
Thank you. So the next question is from Chebet Mutai. She asked, how about partners of those women who tested positive for HPV? Are they supposed to be vaccinated now that we want to break the chain of transmission? Anissa, do you want to answer that one?
It still goes with what I've been saying. The vaccination, as much as we want to talk about it a lot, it's not going to be as efficacious as for those who have not been affected. You can still get it, you can still recommend it, but the efficacy is not as good.
Thank you. So just to a little bit to add on what Anissa said, yes, you can get vaccinated. Yes, some people will want to get vaccinated even when they're 45 years old. However, key here is the efficacy of the vaccine decreases as you become older. The other thing is that's because your immune system is not able to fight off the infection very well. The other thing is, or mount a response very well. The other thing is, key here would be screening. Screening. And by screening, we can prevent almost 99% of these cancers. So the next question was regarding the same. Would you vaccinate a 40 years old male or female client who has been treated for vaginal warts 7 years ago? I think we've just answered this question. This question was answered in the slide in the presentation. However, I'll request Kennedy to answer this again. What's the screening percentage for the HIV population in Kenya? Percentage for the HIV population in Kenya? Kennedy, do you want to take that one?
Okay, the screening percentage.
Yes.
Okay, so I think we don't have a data specifically for the HIV population group, but it has been clamped in terms of what percentage we have screened as a country. And so far we are at 48.1%. And our target is above 70%.
Thank you, Kennedy. So Anisa had also shared a slide with the percentage of screening, where she said currently, I think worldwide, countrywide, we have screened around, current screening has been, last year's screening is about 13%. And currently this year, 17%. Now, the other question, there was a similar question regarding the same in Nyanza region, why do we have a higher rate of cervical cancer? So the western region of Kenya has a higher, it is one of the areas with a very high prevalence of HIV. And persons with who are HIV infected basically have a lower immune system. They're not able to clear up the HPV infection. So this infection basically persists in these women, and eventually it will lead to development of invasive squamous cell carcinoma. However, again, there's a screening guideline for this specific population, and we've already touched on this, so I won't go more into that. Let's move on to the other questions. I think there's a lot about vaccination, and we perhaps Dr. Nisa could slightly talk about, so there's a case by Claire Otieno. She asked a female who's aged 31 years. She did a cervical cancer screening in January 2023. The results came out at ESCAS. She was then treated with polygynex pessaries and advised to repeat a pap smear, an HPV test after 6 months. Unfortunately, she hasn't done any of the tests up to date. So anyways, let me request Dr. Anisa to elaborate a little bit on patients whose pap smear comes back and the result comes back as ESCAS. How do we then go ahead in management of such patients?
Okay, so first of all, I really want to know what the polygynex was treating. Did she have like another vaginal infection, like bacterial or fungal, to explain the pessaries? But ASCAS does not get treated with polygynex. This is already a change that has occurred in the cervix. It means that there's atypical squamous cells, but the pathologist has not been able to determine the significance of these atypical cells. They could just be normal because of an inflammatory reaction, or they could be on their way to become cancer. And so for these patients with ASCAS, the recommendation is that you do an HPV test so that you know if it's HPV-dependent ASCAS or HPV-independent ASCAS. If it's HPV-independent ASCAS, you just screen them after 1 year, and most of them have resolved. If it's HPV positive or HPV dependent ASCAS, then you go ahead and do colposcopy with a biopsy for them to make a diagnosis with tissue compared to just a pap smear. So I would recommend for her, if she's able to do this HPV test, that would be great.
Thank you. So the next question is from Betty Kandagors. So she asks, how do we handle clients who test HPV positive for other variants? By other variants, I mean other high-risk HPV variants. So this is pretty much, you would just manage them the same way as you would manage any other patient of HPV. And now the next question is from Kuresha Ali. She asks, what's the management of a client who tests HPV positive with but PAP and VR are negative. So Anissa, would you want to answer that?
On hill that I will die on. I will take a HPV test any day and ignore a pap smear and a VR. All right. And I think I gave you the numbers because numbers don't lie, and I always trust the science. HPV test is very sensitive. And if you have a virus, then we look for changes. So I'm not going to look at the most superior screening test. So if these other lesser screening tests are negative, I will use the most sensitive, the most high performing, and go forward, do a diagnostic test on this woman, run a colposcopy, and biopsy her if I need to.
Okay, thank you, Anissa. So now just on that, I have a question of my own. So if you have a patient who's has HPV, she's which is negative, however, she has LCIL that was detected on pap smear. So how would we, sorry, I'm asking you this because this is a question that was asked to me by one of the doctors. So so she has LCIL that is negative. She has a HPV test that is, sorry, LCIL on pap smear and an HPV negative. Yes, so how would you go about in management of this patient?
So whenever I see an LCIL, I get happy because it means that the body is fighting whatever infection or whatever process is going on in the cervix. And so I will just give them some time, give the bodies time to do its job. Because remember, we said most of the women, 80% of the women will clear the virus, whether they had it or not, or she could be having some kind of bacterial infection or fungal infection to cause some kind of changes. But as long as she's HPV negative, I'm not entirely worried. So I'll give her time, rescreen her in about a year. And if she does turn positive for HPV, then I'll do a colposcopy. If she's not able to do HPV and repeats her an pap smear, maybe it gets the same LCIL or something different, you go ahead and do a biopsy. I always trust a tissue sample compared to a cytology sample.
Thank you, Anissa, and I'm sure the doctors online and they've heard the answer. So the next question, Kennedy, would you like to take the next question for the for patients who have already been vaccinated and they develop? Sorry, the question is there a chance of getting cervical cancer despite getting vaccinated?
Yes, though I don't have a documentation on the same, but again, getting a vaccine doesn't guarantee that you may not get cervical cancer in future. It just reduces the chance of getting the cervical cancer. So yes, you can get a vaccine, but how is the body going to react to the vaccine? So it is not that you are going to be totally immune of getting cervical cancer in future. Still with the vaccination, screening, I think, is still recommended to the population. Thank you.
Thank you so much, Kennedy. Yes, thank you for the answer. But yeah, yes, vaccination does not guarantee that you will not get cervical cancer. For vaccination will just prevent, but it's not 100%. It's not a guarantee that you will not develop cancer. So screening, vaccination and screening go in hand. So the last question. So Anissa, this is I'd like you to take this question. Patient received two doses of HPV 20 years ago. Does this patient need another test, considering that this patient's age is 47 years old?
So, good one. So in fact, I think the person is asking, does the person require a booster shot?
Yes.
Yeah, because they received 20 years ago. We do not know yet, because the studies that we have, it has shown that the effect of the vaccine or virus, the effect of the vaccine can last up to 25 years. And so currently the studies are to try to determine whether a booster is required or not. But for the most part, because of understanding how the disease processes are, it's shown that she's already been exposed probably. So she does not need a booster because she's already had the previous immunity. Because we have to understand why we give the vaccine. And I mentioned this in the presentation, when we're giving the vaccine, it's so that when you get the infection, your body can be able to launch an even stronger and more sustained reaction to the virus and be able to suppress it and keep it from persisting and it becoming cervical cancer. So if you've already received that particular initial boost, so to speak, of the vaccine, and you've even gotten 2 doses, that's a very great thing. And you continue with your regular screening, that has been shown to be sufficient, and that is the current recommendation. So boosters have not yet been shown to be scientifically useful.
Thank you, Anissa. But I know I said this is the last question. Just one more question on that, on the doses. So I know there's this 1 versus 2 doses. Can you briefly elaborate 1 dose versus 2 doses? And can 1 dose suffice in patients who've just got 1 dose and they've not got a second dose?
Yes, so we've had studies from Costa Rica, from Kenya, led by our very own Nelly Mugo, so proud of her, and other parts of the world, even Rwanda, that have shown that the girls and boys who received 1 dose of the HPV vaccine, that it was sufficient in maintaining the reducing the risk of incidence of cervical cancer or CIN2+. And so currently, recommendation is to give 2 doses. Most of the national guidelines have not changed and they still recommend 2 doses. But if someone has gotten 1 dose, it is considered still sufficient. So whether 1 or 2, you're still covered.
Okay, thank you so much, Anissa, and thank you so much, Kennedy, for your wonderful presentations. I'm sure we've all learned a lot. I know the conversation and the questions are endless. However, all good things come to an end. So this is the end of our presentations, and thank you all for being a wonderful audience. Have a good afternoon.
Thank you so much for having us.
Good day.
Thank you, and bye.